Rated disc osteophytes, C3-4, C4-5, C5-6. We're starting at C4-5 as we always do, the middle disc of 3. Our patient has kind of an issue with the thyroid cartilage. It's pretty big. You can see from the lateral view we are in the disc at 4-5. Everybody agree? All right, so we're going to get a little deeper in. Shot. I need a shot. That's it? Shot. And we're going to do what's called a discogram, where we inject some dye. Now our patient here traveled from Canada, right? Canada, I think. Close to Canada. Oh, was it Mississippi? Sorry. Shot. A little dye. So you can see the dye is leaked out through a tear in the back of the disc. Must be a big tear because it literally went out quickly. Yep, thank you. And show them C2, C3, C4, C5. So we're at the C4-5 disc. We've done our discogram. We're going to place the guide wire now. And then bring our dilator down. Shot. Looks good. This patient has 3 herniated degenerated discs. They have disc osteophyte, which is bone spur and disc herniation both at the back, that is pinching on the spinal cord and the nerves. So we're going to go back there and clean all that out as much as we can endoscopically. There will not be any fusion done, no artificial discs. We're doing all of this through endoscopic spine surgery. Endoscopic spine surgery is the new way of treating these conditions without doing major open surgery. We still have our patient asleep. Yes. Incision. Now we couldn't broadcast the last surgery because that patient did not want to be broadcasted. He was actually a workman's comp injury to his spine, and he chose no broadcast, but we did obviously complete the surgery. Everything went well. He's recovering. He'll go home in about an hour or so. Shot. All right, I'm removing the needle, leaving the guide wire. Now some people ask me, can you do this kind of surgery if you're on blood thinners? The answer is yes, but you have to stop those blood thinners appropriately. If you're on Plavix, for example, you're going to want to stop about a week before your surgery. There is going to be a little more bleeding than normal, but I tell patients you have to be willing to take that risk of having a blood clot. You know, I'm willing to take it as long as you're willing to take it, but it could be a serious complication, and you have to be willing to do that to have the benefit of the surgery. Doesn't matter what kind of surgery you have. When you're on blood thinners, you're going to be at an increased risk of blood clots no matter what kind of surgery you have. So the nice thing about this surgery is that it's less invasive, smaller incision, so there's going to be less bleeding than an open surgery like an ACDF or a fusion or artificial disc. Shot. Okay, we're in position, AP, with our guide wire. You can see we lose a little more blood on these cases because, again, patient was on Plavix. In this case, stopped 7 days ago. Shot. Some people are on multiple blood thinners. I need an AP. I need it centered. You're off to the side. Perfect. Looks good. Back to a lateral view. A lot of arthritis here. A lot of arthritis. So, this patient did not want fusion, did not want metal. Wanted us to fix these discs as best we could endoscopically. Everyone agree we're at 2, 3, 4, 5. All right, at this point, I'm at the front of the disc and the annulus. Now I'm going to use the tapered tip of this device to push through. Shot. And I'm going to go into the disc like I've started doing. Now, to be safe, we have to take a way to advance this with a measured amount of force. And that's why we use a mallet. Mallets are surgical tools used in spine surgery, orthopedic surgery, and they're used to deliver energy to move things, usually, in a controlled manner. And that's what we're doing. A very controlled manner. I'm giving small quantity of energy. And we're right at the back of that disc where the herniation is. Go ahead. Let's show the audience what we're going to do here. We're going to do the entire surgery. Henry, can you see this?
Yes.
We're doing this whole surgery through this tiny tube. No big incision. Imagine if, look at the bleeding with a tiny 4mm cut. If we had done a big incision, there would be blood everywhere. So open surgery is far more bloody than minimally invasive endoscopic surgery. We prefer minimally invasive endoscopic, so there's no bleeding. There's no trauma to the tissues in there. If I was doing an open surgery like an ACDF fusion or a artificial disc, we'd have to make a big cut. We'd be pushing all the tissues over and cutting through them and doing damage. And we wouldn't do it on purpose, but that's just part of those surgeries. I did those surgeries for many years. Got it. Now we're going to watch the tip to make sure the dilator tip doesn't go in much further as we advance. You don't want the dilator tip going in and spacking out a little bit. I'm going to keep an eye on that. Almost there. Sean, I need some distraction. I need a little shoulder pull. I need a little inline traction. On the count of 3. 1, 2, and 3. Sean? Perfect. A little more, and we're done. All right, everybody's done. Thank you. Relax. So we are now seated with the tip of this beautiful tubular retractor, 4mm in diameter. We're seated at the back of the disc where the tear is and the herniation is and the bone spur is. We're going to try to get rid of the tear. We're going to debride the tear. We're going to get rid of the herniation and bone spur as much as we can safely. And then we're going to go to the next disc. All right, any questions from our audience so far? You're watching a state-of-the-art endoscopic spine surgery, replacing fusion, replacing artificial discs. Now this patient is not a candidate for artificial disc surgery. His discs are too degenerated. So his only other option would be fusion, which is a horrible surgery to do, and I don't recommend it. So I got a call just a few minutes ago from a patient of mine who had laser surgery done 3 months ago. And he lives in the Virgin Islands. I'm not going to mention his name. And he did fantastic after his laser surgery. What's going on over there? I don't need any more trauma today. So he calls me because he's in the emergency room in the Virgin Islands. And he says, Dr. Deuk, I need to come to Florida for you to do surgery. And I thought, oh boy, something happened. What happened? His wife tells me he was working on the roof of his house and he fell off 20 feet. 20 feet from the roof to the ground. And has fractured his entire spine. Thank God he's not paralyzed. That's the first and foremost. He is not paralyzed, thank God. And I said, I can't treat those kind of fractures here. So he's going to go to Miami Jackson Memorial Hospital and get treated. I told him that's the best thing to do. But he insisted that that his doctor should call me and that I would help manage him, and I did. It's just that we don't do those kind of complex fracture cases. You know, he has what's called burst fractures. We don't do those here. So, thoracic burst. Thank God he's not a spinal cord injury. He's so lucky he's not paralyzed. He has no idea. 99% of the time, that kind of an injury, falling 20 feet off a roof, is going to cause a complete paralysis. So he's very fortunate. But I was touched by the fact he wanted me to fix him. Didn't trust anyone else. And I told him, you're going to the best place you can go. So he was happy with that. All right, here we are fixing a herniated disc, degenerated disc. That's what we do at Deuk Spine primarily. And this patient has severely degenerated discs, and that's what we're working on right now. You can see the laser fiber down there, and we're removing the herniations as we talk and work. A lot of scar tissue here. Degenerative disc disease is all about chronic inflammation and all the effects of chronic inflammation. Scar tissue, calcification, bone spurs.
We have a question.
All right, we'll take our question from our audience.
This comes from Lotan B on YouTube.
Hello, Lotan. Thanks and welcome to our broadcast. Sorry we couldn't show you guys anything earlier, but we respect our patients' rights to privacy, and if they don't want us broadcasting, we don't broadcast. So this is our first surgery for October 13th, broadcasting live. Thanks for joining us.
And their question is this laser surgery or ultrasonic? There are surgeons that say laser surgery only works for very specific situations. Is there a difference between ultrasonic and laser? I would really love to know your opinions because I have to decide which direction to go. I have 0.5 cervical disc extrusion.
Yeah. The decision you want to do, my friend, is you want to do this surgery, the Deuk laser disc repair. I'll try to explain why. First of all, understand that I can do ultrasonic surgery as well. I've done it in the past. It's more of a gimmick, and it's really primarily used to remove bone, okay? So if you're having a laminectomy and you want to take the bone out, these surgeons are using the ultrasonic device to remove bone. Normal bone, by the way. The ultrasound does not remove disc herniations. It cannot. Ultrasounds remove bone, not disc herniations. So already right there, you don't want to use an ultrasound for a herniated disc, period. It's just a gimmick. I know who you're talking about down in Florida. I don't recommend it. The ultrasound I've used for years. We use it to take out bony tumors that are really hard. They're calcified. And the laser can do a better job than an ultrasound. And the ultrasound, by the way, what it's removing is things you don't want to remove. It's removing your natural bone that God put there to protect your spinal cord and nerves. Go see what they do. They do an ultrasonic laminectomy. You don't want a laminectomy. Laminectomy will not fix your herniated disc. I promise you that. So don't trust that technique. I wouldn't do it myself. I wouldn't recommend you do it. That's the best I can tell you. An ultrasound machine would cost around $30,000 to buy, and you have here in the operating room. My equipment, the cheapest thing I have in here is the laser is $130,000. Do you really think that we couldn't have an ultrasound here if we didn't want one? Of course we could. How often do you see me do ultrasonic surgery? Never, because it's garbage. It's just a gimmick and people are falling for it. Now, what is the doctor really doing in there after he removes your bone? I don't know. But he's doing probably the same thing that everybody else does, which is a discectomy. But he's not using the ultrasonic device to do the discectomy. The advantage of the ultrasound is that it doesn't remove soft tissues. Go look it up. It's safe around nerves. It's safe around disc herniations because it won't take the disc out and it won't damage the nerves. So all it does is take out bone, but you don't want that bone taken out because the bone isn't the problem. It's the herniated disc that's the problem. Whoa, careful, please. You okay? Yeah. All right, these pieces of herniation, we're zapping them away with the laser. They're coming out beautifully. This is the tool of the future of spine. Unfortunately, most doctors don't know how to use it, but it is the best tool. It is the tool that we choose to use. This is a $130,000 machine, okay? The ultrasound is a $30,000 machine. Just based on price, which one do you think is better? It's obvious, right? If you're going to buy a car, would you rather have a $130,000 car or a $30,000 car? People aren't stupid. They can figure this stuff out. The ultrasound is just literally a gimmick. We use ultrasounds all the time here at Deuk Spine. We use it not for removing bone. We use it for localization. Like when we do piriformis muscle injections, we use it to find the piriformis muscle and then to put a needle in it. The reason we use ultrasound is the alternative is an x-ray machine. And x-rays are, you know, radiation is bad for patients and staff. So using the ultrasound is good. And yes, that machine is a $30,000 ultrasound. We have how many of them? Two of them, Luis tells me, okay? So we could certainly do ultrasound if we want to. We don't do it because it's garbage. It doesn't work. And it's not directed at the right place. We don't want to do a laminectomy. If we start taking your lamina out, then we're going to have to fuse you eventually because we're going to destabilize your spine. This surgery you're watching is done with the laser. We don't destabilize anything because we're not taking the parts of your spine out that you need, okay? Think about it this way. If you need your house to be cooler, you get an air conditioning unit installed, right? You don't take the roof off your house. Laminectomy is considered unroofing the spinal canal. It's like unroofing your house. You don't want that done. It's way too aggressive to get rid of the heat. Nobody does that. You know, but I'm sure there's some people that could sell you on it. You got to be smarter than that, though. Don't fall for those kind of gimmicks. That's a piece of herniation. The most important thing is look at our results of our patients. The surgeries we do fixes the problem they come here for, okay? And like I've said before, sometimes people have additional issues like piriformis syndrome or sacroiliac joint problems or facet joint problems that are closely related because they're in that same area that we're operating. And we have to address those separately. But none of that requires an ultrasound. Okay, ultrasound we use as a diagnostic tool, not as a therapeutic tool. Unless we're taking out calcified meningiomas or calcified spinal tumors. All right. What other questions do we have, Henry?
Yes, we have another question from Lotan B once more on YouTube. And they asked, what's your opinion about stem cells as options? Many athletes and celebs have gone to bioaccelerator. I've heard a lot of good results from stem cell therapy in Panama and Colombia as well.
Yeah, all right, great question. Yeah, we believe in stem cell technology at Deuk Spine, 100%. Stem cells and PRP, we do it here. But we don't do it for discs. It doesn't work for discs. It works for other joints like knees, hips, shoulders, sacroiliac joint, maybe the facet joint. So yes, there's a role in musculoskeletal medicine treatment for stem cells. And we do it. We do it right here. Dr. Patel does it. And he treats athletes just like the other guys do. So my point is stem cells are necessary in certain conditions, but definitely not for herniated disc. I wouldn't do it. We've tried it, by the way, in case you're wondering. We tried it in a few patients, and the results were not good. I mean, the patients had a lot more pain. Inflammation. It was horrible. They were, huh? Thanks. They were having, you know, horrible inflammation after the surgery. Like I've never seen that before in any of my patients. So we decided that we weren't going to do it anymore. For good reason. So stem cells are good. PRP is good, but it has to be put in the right place. And the spine, the disc is not the right place. Not for disc problems. Great question. There's another piece of herniation right there. So what we've learned about this particular disc here, the 4-5, is there's not a lot of herniation. It's mostly old herniation, scar tissue, and, oh, come on. Trying to get rid of this piece. I need the grabber. When I ask for the grabber, I'm asking for a pituitary rongeur. It's a surgical tool that is used to go down that hole and grab things out, like pieces of herniation. Don't move that. Every time you move it, I can't get it in. All right, we're pretty much done here. I don't see much else. There's a little bit here. We'll work on this and then we'll be done. Great questions, by the way. That's an old herniation right there. Try to get it out. It's so big, I'm going to have to cut it in half with the laser. So just as a rule of thumb about the ultrasound, ultrasounds remove hard things like bone. And we don't want to remove bone here. We want to remove soft things like a herniated disc. Look how the laser is so efficient. There's nothing better than the laser, folks. The problem is the lasers are expensive. People don't want to spend the money on them. And they require the endoscope. And if you're not doing endoscopic surgery, you don't need a laser, basically. So you have to use it with endoscopic surgery, like we do. If you'd use this with open surgery, there's no point. So when you hear surgeons, spine surgeons, talking about how laser is not necessary or it's not safe, they're talking about using it with open surgery where you can't see the tip of the laser, you have no idea what it's doing down there, and certainly you can injure the nerve. If you can't see as a surgeon where your tool is, then you can hurt something down there, okay? So the first lesson you learn as a surgeon is never stick your tool where you can't see the end of it. So can you guys see the end of the laser here? The answer is yes, you see it right there. And the only reason you can see it is because this is endoscopic. If this wasn't endoscopic, you wouldn't be able to see it. That's why other surgeons who don't do endoscopic surgery criticize laser, because they're not able to see it. And it does become dangerous. Let me ask you a question. If you were standing in a room that had your family and there was a bad guy there trying to hurt your family and you had a gun, would you shoot the bad guy if the bad guy was visible to you and you could see them? Of course you would. If they're trying to harm your family, you'd shoot them. Okay? This is not about guns, by the way. This is about a concept of being able to see what you're doing. Now, let's say the lights went off in the room. You don't know where the bad guy is. You don't know where the good guy is. Are you going to start just shooting blindly in the room? No. And that's the analogy for this laser, is that surgeons who can't see the tip of the laser because they don't do endoscopic surgery, that's like having the lights off in the room and just shooting your gun wildly. I agree with them. They shouldn't be using a laser. But the surgeons who can see the laser, because they actually, use an endoscope, like I am, the laser becomes the best tool in the world for this kind of surgery. So, anyway, just thought I'd share that with you. Dr. Cantor, who does the ultrasonic surgery and has been a big promoter of that, he doesn't do endoscopic surgery. You can't fit the ultrasound down this tube right here. The ultrasound is big. It's thick. And it has to be used, maybe with a microscope, but you don't do it endoscopically. Okay? So hopefully that's a long-winded answer, I know. But that's the truth. Any other questions, Henry?
No current questions.
All right, let's show the audience, why do herniated discs actually cause so much pain for people? What is it about a herniated disc that causes the pain? Then the tear. And that's what I'm working on right now, the back of the tear. Cleaning out, getting rid of the herniated material, getting rid of the source of the inflammation.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right. Now, we are just about finished with this disc. This is the number 4-5. And after we're done here, we're going to go fix the number 5-6, right? So, you know what? Let's show the audience what exactly the Deuk laser disc repair does to fix these discs.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own and can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
What was the reasoning for your daughter's name is Charlotte?
It was either going to be Eleanor or Charlotte, something traditional.
Uh-huh, of course. All right, welcome back. You can see now why we do this type of surgery. It's really to remove the herniation, folks, you got to get where the herniation is stuck down, unfortunately, in the back of the disc where the tear is. And there's no way to get that out unless you use very special tools to clean it out. Now, when I do ACDF surgery, I use a special type of scraper. It literally looks like an ice cream scooper, but super aggressive. It's got a sharp blade on the edge. But we can't fit those down here. Right, Luis? It's impossible. So they're too big. So you have to use something else that's sharp, and that is the laser. All right. I'll make an adjustment. Oh, come on. Yeah. What's going on over there? Okay. Same machine we had problems with before? Huh? I don't know what that means. Yeah, this is something that Luis needs to supervise and manage. What's going on, Luis?
I need to check it, but
Those are,
refurbished.
I don't care.
Yeah, I know.
The issue is, are they working or not? And if it's not working, you
Well,
need
we're
something
working
that
fine,
is.
but they're not like let's say consistent.
Then we need to get ones that work consistent. Okay?
Yes, sir.
Yeah, so just
You
work
don't
on
like
that.
the other ones that we tried?
Which one?
The one that are like the guy come over here and bring
I don't remember. What was
You
my
said-
criticism?
you want more pressure. You the pressure
Oh,
was
yeah.
good, but you request like a more and more, and they
So-
don't have one. Yeah.
What's wrong with the pressure bags we've used for years?
Well, the manually one. You can
Huh?
use it. The manually one. We used to use manual. Yeah. We used to have a manual.
I don't know. What
That's what we used before.
you're talking about the one where we were paying $50 a case? We kept popping them?
Yes.
No.
Yeah.
Why would I want those?
But that's what we used all the time before.
No, I never popped them before.
Well, that's the nurse. It's not. You know what I'm saying?
No,
It depends on the.
I don't know what you're saying. All I know, I'm not getting good irrigation here. I need you to get that irrigation working. I can't do the surgery without proper irrigation. It is, yeah.
Thank you.
But it's not great.
Whatever you're doing, you need to put a little bit more pressure. A little bit more. Yeah. Not to explode the bag. I think that's
Yeah,
good.
it's better.
That's good. Yeah.
A lot of herniated disc pieces.
We have a question.
Sure.
This comes from YouTube, from a name I'm sorry that I can't pronounce, but the question is, will the herniation recrudescence
Will the herniation recur?
recur? Yeah.
No, it will not. Unless the patient does something they're not supposed to do after the surgery. So, as long as the patient follows the instructions, they will not get a recurrence.
Good. Can you grab it or are we good?
We're good.
We good? Okay, lights on, please. Thank you.
There's no reason for the disc to recur herniate. You can see how tough they are. They don't just drain out. They have to be pushed out through lifting and physical activity, strenuous activity. So patients have a period of time where they have restrictions on their activities. Can't just go and play football the next day unless you want a recurrent disc herniation. One down, two to go. So I guess we are doing the ulnar nerve today. Could you do something, Oscar, please, when you see that? It should be automatic. All right. Bring our fluoro in.
You can come, Jordan.
What's working? We have no idea. We're not using it. How would we know if we're not under the scope?
Oh, it just probably you see the pressure and it's constant. Yeah.
Of course it's back because we're not using it. What do you think happens when you let the air out of a balloon that has 300 psi? It drops. So when we start using the irrigation, that's when we need it. As the water is flowing out, we need it to be, come on, hurry up. We need it to be 300.
We need the seating off, please. Seating off. Thank you.
All right, what other questions can we answer for you guys?
No current questions, but we do have a comment from SPX 730, and they said, "Good day, Doc."
Thank you. Appreciate it. Trying to have a good day. All right, check it out. See how small that hole is? We just fixed one disc with that small hole. Next, we're going to, is that my picture? Yes, sir. All right, next we're going to go to the one below. And that's going to be what? 2, 3, 4, 5, 6, right? C5-6? So to do that, I'm going to pull this tube out. You guys can see me doing it. Shot. I'm going to use X-ray to guide me because otherwise you can't see. You can't really feel good enough. You got to watch it happen with the X-ray. Shot. I should be right near the edge. I am. I'm coming out. Now, doctor, he's relaxed, right?
Yes.
Because if he's tight, he's going to shove this tool to the side. Shot. Can feel it right on the edge. And I don't want to lift. I just want to come out and move down. Jeez. Shot. Oh yeah, I'm out. Shot. All right. I need to figure out which side I'm on. I think I'm on my side of the spine. Shot. All right. It's a little better. Let's go AP quick. Again, I want to keep the tip planted on the spine. AP shot. That's perfect. I'm going to come south a little bit with the tip of the dilator and try to make it to the next disc. Shot. A little bit further and we're there. Shot. So what makes it shot hard, AP, is that quite literally this guy has a really thick thyroid cartilage. It's calcified. Quick, not a slow. Ah, that looks pretty darn good. Get me a better. Yeah, that looks good. I need to be lateral. So we're actually right where we need to be. I'm impressed. You happy with your ET tube? All right. So, shot. I'm going to plant it. And then I'm going to try to get a better trajectory. Shot. All right, give me an AP again. Let's just make sure we're still in the middle. Quickly. I can't tell. Let's get that straightened out. That looks really good, actually. Looks really good. Take that. Back to a lateral. So I'm verifying the position of my dilator tip relative to the front of the disc at C5-6 on both AP and lateral views. Now that I'm sort of going into the disc shot, I've got to try to angle it down a little bit because he's got a really tough neck. Shot. I think maybe, I don't know his history with his neck completely, but it seems like there's some kind of scarring or something that may have happened. Some people will get treatments like radiation treatment. Shot. Shot. I don't know his entire history with that kind of treatment. Shot. We're going to do our discogram. Shot. Should be good. All right, so it leaked out the front. Shot. Any questions from the audience? Shot.
No current questions, but we do have a comment from Willie Versal on Facebook, and they said, "This is really impressive. A spinal issue patient commenting from Spain."
Oh, thank you. I'm glad you like it, Raytech. So, you know, this is advanced stuff. Unfortunately, most spine surgeons in the United States don't do this kind of surgery because To be honest, they make too much money doing fusions. This pays a lot less. So I haven't met a single spine surgeon besides myself that is willing to do better surgery for a patient but take a pay cut. There's not many that are like that. Shot? And a lot of it's being driven by industry. These companies that manufacture implants that get bolted onto your spine, like plates and screws and cages, they're pushing sales. As a matter of fact, when I came out of my training as a neurosurgeon, I trained at the University of Florida in Gainesville. It was a top neurosurgery program in the country. It probably ranked #1, but it's hard to say back then. But Seattle, Washington, University of Florida, and the Barrow Neurological Institute, probably the top 3 in the country and the world, as a matter of fact. And we were taught from day one to do fusions on spines. And that's all we did was fusions and artificial discs. Shot? You know, we did stimulators and morphine pumps and all that other stuff too. But my point is, it was very much a relationship, a marriage between the neurosurgery and orthopedic surgery department and the companies that manufacture metal and for implantation in the human body. The relationship was so strong that there was so much money being made, like hundreds of millions of dollars at each institution, that the companies would make sure that the representative reps that work there with the surgeons, they would take you out to dinner, drinks at the bar. I mean, if you were a decision maker to put metal in, they would wash your car for you. They'd pick your kids up from school. They would bring you lunch. I mean, they do everything. Massage your feet, suck on your toes if you're that kind of person. Never happened with me. But I had a guy working for me. He was a neurosurgeon. He was a real work of art. Unfortunately, I'm not a good judge of character, so I get burned a lot by people. But that said, this guy started putting screws and cages and plates in, and he was putting the screws in from one company. He put the cage in from a different company, and then he put something else in from a third company, the bone graft. And I'm wondering, why would any surgeon use 3 separate companies? And then I saw the reps. They were female, and each one of them apparently was sleeping with the guy. And he was married with kids. So, you know, there's just a horrible, selfish, disgusting industry of implants and money, and the patients are the ones getting screwed, literally getting screwed. So I decided that that's just not something I want to be part of. And I was a big metal guy for years because I didn't know any better. That's how I was taught. Started doing these surgeries, learned the cervical from the Koreans, South Koreans, and then a German surgeon. And then I started modifying it, making it better, made the Deuk laser disc repair. But the truth is that unfortunately, the industry of spine surgery and orthopedics is massively controlled by companies that make billions of dollars a year selling these implants. And the patients have no idea this is happening. The government tried to stop it, but unfortunately, our government is just as corrupt as everyone else. For a while, they got some traction where the government's saying, hey, you're not allowed to buy doctors steak dinners, not allowed to do anything nice for them to get their business. And I was very optimistic at that point that things were going to get better. But then, of course, the politicians started to get cut in. You know, what really was happening was these companies were not greasing all the palms that needed to be greased. Who is the guy in jail right now? The Mexican drug lord that's El Chapo, okay? They've had El Chapo for a few years. You know what El Chapo has told us under his interrogation? He said, I'm not the real drug lord. There are politicians in America and Mexico both that are in charge of the drug trade. If you want to stop drug cartels and drugs from entering this country and being sold, you have to get the politicians who are involved. So, unfortunately, it's just good old-fashioned corruption. And I'm one small voice, one little squeaky noise. You know, you remember that movie, The Whoville? What was it called? The Grinch? The Grinch, right? The Grinch that stole Christmas. Remember Who's were like an entire little country that was on a snowflake, right? Drifting around. All those little voices. Anyway, that's me, one little voice. All I can do is teach people the truth, but they got to choose if they're going to take the red pill or the blue pill. They're going to stay in the matrix, or if they're going to wake up and realize just how bad things really are and do something to fix it. Everyone gets angry with me to fix it. I get people that come here for laser surgery and they find out their insurance won't pay for it because they have bad insurance. And they go online and they bash me like I'm the one who chose their insurance. I love it. I had to respond to some guy today who was bashing us on YouTube or Google. He gave us a 1-star and said, "You guys asked for $30,000 for the surgery." I had to respond and say, that's because your insurance is Medicare and they won't pay. You know, insurances don't want to pay for what's called elective surgery, which is basically surgery for pain, like this stuff. So when insurance doesn't want to pay, you have to pay. And if you have to pay, don't get angry with the doctor. Get angry with your insurance. I just got a bill from my surgery. Okay? United Healthcare. I have United Healthcare insurance. I had my sinuses opened up because I can't breathe. Literally suffocating. Because I had a broken nose when I was in high school playing basketball. So guess what? I get a bill in the mail today for $27,000 because United Healthcare didn't pay for the surgery. Now, you know, I understand that happens. And that's why we ask for money up front. But people shouldn't be pissed off at me when their insurance doesn't pay. They need to be pissed off at their insurance when their insurance doesn't pay. So we're trying to help people get the care they need, but I can't fix their insurance overnight, you know. They're going to have to deal with that. Anyway, what questions do we have from our audience?
No current questions, but we do have a comment from Lotan B, and they said, "Looks like you do amazing work. So nice that you do all of this live with a Q&A. It took the healthcare system 17 years to start recommending exercises for diabetic patients. So I truly believe in the new tech."
Hey, thank you for making that comment. I appreciate it. You're right. Exercise for diabetes, right? I mean, how important is that? It's very, very important. You're going to be burning the sugar out of the blood when you're exercising. So that's, you know, I know a lot of people who use diet and exercise to control their sugar. I do, except for me, I eat everything and I don't exercise, so I do the opposite. I'm a good example of what not to do if you ever need somebody. But then again, my sugars aren't that bad, so. That said, but thank you, I appreciate the compliment. We're here to teach. You know, we like teaching. The thing about it is I've been teaching ever since college, probably before college, even in high school. I had to teach my sister math. So I'm used to sitting down with people and explaining things. And when I was at UC San Diego undergrad, I didn't have any money. I was so poor. My dad had died from colon cancer. I had nothing. Thank God tuition was only $1,500 a quarter back then. But I tried to make some money, you know, teaching, and I taught physics. I was a tutor for physics. And, you know, because there's so many tutors for everything else, right? You know, English, there's like 1,000 English tutors, and I'm terrible at English anyway. So I chose a subject nobody else wanted to tutor, and there was a demand for it, right? Physics. Are you controlling that intentionally? Okay. No, just the floor was moving. So I would charge $10 an hour to teach physics. And I made some good money, but more importantly, I realized something very interesting when you teach, and that is every time you're teaching, you're learning yourself more. Like I thought, all right, I'm an A student in physics. I don't need to, there's nothing more for me to learn. I'm just gonna teach them what I know, but I had to read the book to prepare for the session. And every time I read the book, the chapter, I realized, oh, I didn't know that. I learned something new. There's a herniation right there. That came out of the foramen. You guys see that? Right where the nerve was. I'm going to try to grab it out, but it's pretty big. So physics was like my first real teaching job. And then as I started getting good at teaching physics, I met with Dr. Saltman at UC San Diego, a nutritionist biochemist, and I told him I want to teach for his class in biochemistry. And of course, he was amazing, a beautiful human being, just one of the sweetest people you've ever met. Loved students, loved teaching, biochemists, so very smart. And I started teaching for his biochemistry class and his nutrition class at UC San Diego as a teaching assistant. I didn't get paid. But then again, I started giving, talks and stuff to the class and got really good at teaching. And the more I taught, the smarter I got. You ever hear that? So I taught a few more courses at UC San Diego and then graduated and went to medical school at USC. Then at USC, my God, the material is so complicated. Histology, gross anatomy, biochemistry, and it comes at you like, imagine drinking literally from a fire hydrant. That's the amount of information. It's incredible. So there people were struggling, and I would start teaching them histology. I would have little study sessions. It started out with one person, then two, and then five. Pretty soon I have 10 people sitting there, and I'd give a 2-hour review on histology before the exam, the night before the exam. So then I got into private tutoring, where I would tutor for an individual, and I got paid well, $50 an hour. There are some rich people who don't study very much, let's just put it that way. And again, I had no money. I was dirt poor in USC, living on student loans. Most people won't know this, but I lived off $10,000 a year. $10,000 a year for everything. My tuition was $30 in med school a year, and I lived off 10. That's room and board and travel and gas and everything. Needless to say, I never went out. I was always studying, so I didn't really take that much money. But something special happened at USC. I was recognized. I was valedictorian, first of all, number one, because of all the studying I did. Hey, how are we doing on irrigation? I'm starting to see some haziness. Okay. Maybe. So I ended up scoring the highest in the school has ever seen in neurosciences. And so that when I was a fourth year student, getting ready to graduate, and I matched in neurosurgery, they invited me to teach as a faculty. They said, we've never invited a student to teach as faculty, and we're going to pay you. I said, really? How much? They said $30,000. I said, what do I got to teach? They said, 6-week course. I said, you're going to pay me $30,000 my entire year of tuition to teach a 6-week neuroscience course as an assistant, professor. And they said yes. So my last year of med school, I did not have any loans. I had the $10,000, but that was it. Having trouble, I don't know if we're getting enough irrigation. I don't know. You got to figure out what it is. What are you seeing over there? Is the bag full or empty? Just cold? So, yeah, my fourth year of med school, my final year was a blessing in that I did not have to take loans really, just the $10,000 to live off of. So that was huge. I love teaching. I think I did a pretty good job. I taught neuroanatomy, neurophysiology, neurohistology, and then I went on to become a neurosurgeon, so it was good stuff, you know. All right, almost done here. Gosh, Luis, what do you think?
The
Yeah.
when you stop, when you don't feel it. Pressure still good, Liz? Yeah?
Pressure's good. All right. All right, so then I ended up going to neurosurgery training and taught there as well. So everybody had to teach as a resident. You teach your fellow residents. Huh?
I have something for the scope to prevent fogginess. Maybe I can clean a little bit for the next time.
You're changing it? I just think it was slow. Slow. That's better. Any questions? Gosh, that was way out in the framing. It's pretty cool, huh? How far out you can get there?
Yes, we have two questions. This first one comes from Lotan B on YouTube once more.
All right.
They asked, cervical referred neurological symptoms that cause pins and needles only in the elbow. Oh, wait, let me repeat this. Cervical referred neurological symptoms that cause pins and needles only in the inner elbow area without shoulder pain. Is that even possible from C3 through C7, disc herniation, bulge, extrusion?
Usually not. You need to have a nerve test done by a neurologist. You may have something called ulnar neuropathy, which is a pinched nerve in the elbow. And, you know, that kind of situation, you would not have pain coming from the neck as you're describing. You would not have that. So it fits that description. As a matter of fact, lo and behold, we're doing one of those surgeries today. The last surgery we do, right?
Yes.
Is a ulnar nerve release. We're going to treat that exact problem. We normally don't. But this patient wanted me to do his surgery. I fixed his neck, and he said he doesn't trust anyone else.
That's a carpal.
Huh?
We did a carpal on him too.
Okay. So we're going to be doing that surgery today. Later on, if you stick around. It's called the ulnar nerve release. Just about done here. I got one more disc to go. Doctor? Man. Yeah. They say the herniated disc looks like crab meat. I agree. Sure does, huh, Luis?
Oh yeah. Feels like.
Feels like it could be too, huh? Depends on kind of crabs we're talking about. What kind of crabs are we talking about? Are these blue crab meat? Alaskan king crab meat? Huh?
I don't know
Something
if,
else?
Yeah. I never tried the blue crab.
You never had a blue crab?
Never.
Have you ever had stone crabs?
Some yes.
The full ones in Florida? Ah. Sometimes these herniated pieces just won't come out. You got to break them up with the laser and then grab them. It's always nice when they float out because it makes my job a little bit easier. All right, just about done at this one. Maybe another look-see right there. There is another piece there. You got to get it out. It's too big to come through the tube, so I'm doing what's called a bivalve. Bivalving means you cut it in half. And then you try to take the smaller pieces out. I don't know if I got it. Irrigation looks good in terms of the pressure. No, we're still having a little, haziness. But it's probably bleeding from one of the bone spurs that I removed. You know, there's like a little stump of bone when you remove a bone spur. And that stump of bone loves to just ooze and make your life miserable. What is it?
No,
Everything okay?
everything good.
All right. Done.
Good. Stop off. Lights on, please. Thank you.
I'm going to put a little antiseptic in there. Can you guys see this here?
Yes, we can see it.
So I'm just cleaning out any blood and put a little antiseptic in there. And now we're ready to go on to our last herniated disc, degenerated disc. Come on in there, Jordan. And not an easy surgery to do. Give me a shot. Let's get those cables out of the way. Shot. All right, I got to go from this disc all the way up to the really bad one. You guys ready? Here we go. Shot. Now, if I'm not able to do it, I may have to do a second incision higher up, which is fine. Shot. Definitely out. Let's get an AP. Could feel it pop out. Shot. Quick shot. Perfect. Lateral. So we're good. We're right in the midline on the AP view, which means we're sitting on the ALL, anterior longitudinal ligament. I'm going to slide this baby up right along the highway. Shot. Little bone spur. It's not easy. Shot. There we go. Let's get an AP. Ray. Hold on. Tell me when you're ready. Shot. All right, perfect. Let's go back to a lateral. And give me a second. Let me get the feel. I'm ready. So I'm going to come out just another few millimeters, get to the midline, which I am, shot. And we're going to slide on up, shot. We're going to go right up to the next disc, shot. Give me an AP. Everything okay? This is going to be the hardest one, I think. Shot. That's not bad, Jordan. Go to a lateral. And I'm going to move up a little more north. Ready? Shot. Here we go. Shot. 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 Man, that's tough. AP. How is he doing on relaxation?
Good. I'm just actually getting more right now.
That might be helpful to me. But we don't need too much, okay?
Right.
As long as I can get into that disc, we're good. And I don't want him to be chemically paralyzed too long. All right, here we go. Shot. 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 AP. Oh, it moved. Hold on. Let's just see where that is. Shot. Hold on. Give it to me now. Perfect. A little bit off to your side. Shot. Better. Lateral. Quickly. Yes, that is good. I love it. All right. So let's get one more AP. Make sure we're still in the middle. Take that. Just to make sure. Remember, you never can check too much. It's always good to keep checking and make sure you're in the right place. Because if you're not in the right place, it's always going to be bad. That's perfect. Lateral. I can tell you that the mobilization situation here is not good. Normally I can move this needle, not needle, but dilator up and down easy. Is that it? Like I could slide it easily. Not yet. Shot. Shot. Yeah, it's beautiful. I'll do that. You can start it. Mm-hmm. Shot. Is that it? Shot. Shot. Perfect. Just had to clean the goulash out of there. Any questions from our audience?
Yes, we have two questions. This first one comes from...
Show them the tear, Jordan. Jordan's going to show you the tear on this x-ray. See that? There it is, with the arrow. Can I have a little inline traction? I will take the question. Little inline traction, please, doctor. This is our last disc. Are you giving it to me? Oh. Give it to me, baby. You know, I saw a movie the other night I haven't seen in a long time. Anybody see a movie called I'm Gonna Get You, Sucker? No? You guys are sounding like I'm crazy. Nobody seen that? I'm Gonna Get You, Sucker? It's like an 80s movie. Oh man, it's so funny. All right. Shot. Nice. Last one. I'm going to go ahead and place this tube. You give me some good pull. Shot. I will take the question in just a minute there, buddy. Give me a good pull on the shoulders. Give me a shoulder pull down. Stay with the head, inline traction, not too much, not too much. Shot. Shot. Oh, so hard to get it in there. Sure. That went.
Yeah.
Oop. I missed. Almost done. Just stay there, everybody. Almost done. Shot. That's it. Great job. Whew, that was tough. That was tough. Good luck with that. We'll take the question while Luis is strong-arming this dilator out. I may have to bang it forward a little bit. Stay with the X-ray. Shot. I'm gonna bang this forward just a little bit to loosen up any herniation that might be in there. Shot. That should help. Should come out easier. It's a little trick, guys and gals. If you get a stuck between the tube and the dilator, like if you get some disc material in there, it literally will weld the two of them together. It's called cold welding. No? Luis, you are the man. I don't know what I'd do without you guys. I can tell you, nothing. Can't do surgery by yourself. Oh, by the way, for those of you watching, you might think I'm doing surgery by myself, but there's an entire team of people in this operating room. Most of them just go without mention, but they're all doing their things. And let's see, right now we've got 1, 2, 3, 4, 5, 6 of us actually doing the surgery, and then of course 1 patient, so 7 people. All right, let's take the question. Last disc, so 15 minutes, okay? Doc? What?
Okay. This next question comes from, I apologize, I cannot pronounce their name. I believe they come from China. And their question is this kind of surgery suitable for OPLL?
No. Yeah, so the question is this kind of surgery suitable for OPLL? Funny. Very funny. Absolutely not. And OPLL is more common in Asians. So I do get that question once in a while. OPLL, for those of you who don't know what it is, it's ossification of the posterior longitudinal ligament. And it's a very rare condition. We don't see it much in the United States. However, it happens a lot in Asia, especially Korea, China, Australia. I'm just kidding about the Australia. They're not Asians, right? You're supposed to say Australia is not Asian. You gave me a funny question, so I give you a funny answer. But no, OPLL is basically a dense, hard calcification of the posterior longitudinal ligament, and this is not appropriate for that. Thank God I never see it. But we can still fix OPLL. It just requires a different kind of surgery. But it cannot be done with the Deuk laser disc repair. But thank you for asking.
We have another question.
Sure.
This comes from Lotan B once more on YouTube.
Hello again.
They asked, would you be able to tell if I would need the procedure if I sent you a recent MRI with results translated from Portuguese and a link sign in for the images? Not sure your online system accepts it.
Yes, yes, we do. Tell them yes, of course. We do accept the portal link. You have to give us your login credentials. And our system, we're actually modifying right now. We are literally in the process of updating our form so that when people submit for a free MRI review, that they can use a portal, they can use a CD or a flash drive, or you can mail it in. But yes, we'd be happy to do a free evaluation for you, no charge. We do that for everybody. It's how we give back. Happy to do it. Why don't you go ahead and put the link? Boy, it's tough to get this tube in here. You know, Luis?
What do you mean top? Like
I'm having a hard time sliding it up and down.
that's probably what we matter.
Oh, you mean the top is bent a little?
Probably.
Interesting. All right, well, could be. Yeah, I could certainly tell you if you're a candidate. A lot of people are surprised to find out that when they have degenerative disc disease that they are a candidate for this procedure. This procedure works very well for degenerative disc disease. But it will not work for OPLO. It will not work for ankylosing spondylitis either. It doesn't work for fractures. But most conditions that people have with their spine, it's more of a degenerative type condition, and degenerative conditions do very well with this surgery. 10 minutes, doctor, 10 minutes, I think we'll be done. Almost done. The next surgery we're doing, folks, I think is a 1-level cervical DLDR. So the next patient has just one bad disc. I believe he's from Canada, right? He may be from Canada. And yeah, he's the one from Canada. I remember now. I'm pretty sure he's near Niagara Falls. So our next patient is a single level. We had 2 3 levels today. A bit unusual to have 3 levels. Happens, but not often. Irrigation's good. How much longer? Probably at least 5 minutes, yeah. Yeah, that's fine. Change it out. Got to be able to see. The irrigation does several things. One, it clears out the blood or debris that comes from using the laser and vaporizing the herniation. 2, it actually keeps the tissues cool, because remember, the laser can produce heat. You don't want heat. We're not trying to have heat damage to anything, but so the fluid is cool. It's refrigerated irrigation. Very cold. All right, flipping it. And then number 3, it contains an antiseptic, and it's physiological. We use either lactated ringers or normal saline. Who's out there? Monica? Hi. How are you? It's going. Do not steal Jordan. You hear me? Are you giving him a break? Break's fine. Yeah. But that next patient has a thick neck. And I want to make sure we're optimized in every way possible. Isn't it good to be wanted, Jordan? We're going to be done in about 5 minutes or 3 minutes. Huh? He works for you. Of course he's going to be great. You doing all right, Doc? Literally 3 minutes left. There's not a lot of herniation here at this one. It's mostly just chunks of scar tissue and scarred up disc. There's another couple of herniations right there. See what I mean, folks? They literally just work their way out. And that's not the actual laser. It's the pulse, the sound wave. Remember I talked about it the other day? How the laser creates a pressure wave in the fluid. It's called cavitation. And it helps dislodge. You know, it's kind of like, okay, you know when you're cleaning your teeth and you use that, what is that thing called? The pressure washer on your teeth? Sonicare. 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 Ah. Sonicare, it uses like a pressure burst. So dislodge food. This is the same thing. This is like the Sonicare for the spine. We're done. Let's go ahead and show our, oh, I got a little bit right here. Let's go ahead and show our audience the video. No, not yet. I thought we were done, but I saw one more piece. I'm not leaving it. Let's show the audience the video on how the Deuk laser disc repair works, and then we'll do a comparison video with the Fusion.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, you made it back, and we found a little deposit of herniation off to the side here, and I want to try to get out as much as I can. So we're getting a lot more movement now of this disc. You can see things moving better. Okay, very happy with that.
Right, scope off, lights on please, thank you.
It was a tough case, really tough. Why? Because the discs were so collapsed and degenerated, but we still got it done. And he's got a really calcified thyroid cartilage, so it's really hard to move it and hard to move around. But we got it all done. Because we don't give up at Deuk Spine. At least we never give up easily. But we also don't want to put the patients at risk, so we don't do stupid things. I wouldn't take great risks for my neck. I wouldn't do it to my patients either. We want to make sure we take calculated risks for patients. I'm going to show you how small this incision is. It's quite incredible. Literally 4 millimeters. Take that. He's already awake and not happy with me pushing on him. We call that reflex right there a gag reflex. So when you push on someone's pharynx and they gag like that, it's a gag reflex. All right, see how tiny the incision is, guys? Small.
Yep.
Let's keep pressure because he has Plavix that he normally takes, and I want to make sure he doesn't develop a hematoma.
Monica, can you help me with the camera and the light, please?
What do you want her to do? Take it? Oh.
No, no, fine. It's close. Thank you. Yep.
Folks, go ahead and type up your questions for me. I'm going to come answer them for you face to face. Surgery went well. I'm going to go check on the next patient who's a 1-level DLDR cervical, C6-7, and then I'll come answer your questions. In the meantime, let's show them our comparison video of the alternative type of surgery.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Dr. Deuk here at the Deuk Spine Institute. I'm with one of my patients who's traveled to us from Mississippi, and he came here for the Deuk laser disc repair to be done for a herniated disc on his neck, and he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well, no problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything is gone. A little soreness in my throat. My voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. and I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused a adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
I'm Dr. Deuk, and as you can see, we've just completed surgery on the neck of a patient who has really 3 herniated discs that happened many years ago. And over time, the inflammation going on in the disc that causes all that pain and suffering, the headaches, the neck pain down the arms, that inflammation destroys the disc. And what happens is people start with a disc that looks like this, where they have a nice thickness to the disc, and then over time the disc collapses like that, and it gets skinnier, thinner, dried out, and that's the situation we are dealing with today. Now, the problem is always the same. It's in the back of the disc, and so to get there we had to go through the disc to get to the back, and that's what we just did on 3 discs. Give me 1 second. Dr. Deuk. I'll bring you right back. Thanks. Oh, that's my 3 o'clock meeting. So we went through the disc with a tiny little tube to the back where that herniation is. So even though the disc is collapsed, that herniation is still there in the back. All right, pushing on the nerves. So I had to get through a tight space to the back, work my magic back there using the laser. The laser never fails. It's wonderful, and it did a great job. I guess I'm very popular. They'll just have to wait. Long story short, surgery went well. We were able to fix all 3 discs, number 3-4, 4-5, 5-6. Our patient is waking up. We really lost only a few drops of blood. We counted it as 3 cc's or 3 milliliters, but basically this endoscopic surgery is relatively bloodless. There's no narcotics or opioids used after the surgery. If we had done an alternative type of procedure called an ACDF fusion, which you guys saw a comparison just a few minutes ago, if we had to put that metal plate in and scrape out the disc and put in cages, then that patient would need to be on powerful painkillers for probably months after the surgery. You've heard about people with fusions, they don't do well. There's all kinds of complications that happen. We do those here ourselves. Our patients do quite well with fusions, but why have a fusion if you can fix it naturally with endoscopic surgery? Anyway, you saw the incision was 4 millimeters. We fixed all 3 discs with that tiny little cut. This is probably around 650 surgeries I've done on the cervical spine endoscopically through the front, called transdiscal. We pioneered the technology of debriding the annular tear to clean out the herniation within the annular tear. It's called the Deuk laser disc repair. It's been peer-reviewed and published and presented at many national neurosurgical society meetings, peer-reviewed and published in the medical literature. All right, let's take our questions from the audience.
Yes. Our question comes from Nucleus on YouTube.
I love the name Nucleus. All right.
And they ask, hello, Dr. Deuk. Are you currently or have in the past trained Deuk laser disc repair to anyone?
Great question, Nucleus. The answer is yes. I have trained another surgeon, partially, not completely. I stopped the training because there really wasn't a need to continue at the time. They're a good doctor. It's actually Dr. Patel, my partner, and he was very busy with his pain management stuff. So I could reactivate him any day that I needed to. I also train over these broadcasts. I have lots of surgeons from around the world that watch. They're spine surgeons usually, and they enjoy watching the surgery and learning from us. So I guess you could say that I do the education virtually over the internet, but of course to actually be able to do the surgery you need hands-on training. And as far as hands-on training goes, the only doctor I've ever trained hands-on is Dr. Patel, Dr. Fda Patel, and someday he'll be helping me do these cases. Right now he's a very busy interventionalist.
And that is it.
That was our only question. I thank you all for joining us. Apologize for the telephone intermissions. And we have the next patient is from Canada, near Niagara Falls, and he is here to fix one disc herniation at C6-7. He does have a thicker neck, so it's going to be a little bit of a challenge, but hopefully we'll be able to get it done. And then the final patient for today, our last one, will be what's called an ulnar nerve release. And you probably haven't seen me do this surgery. I think I've done a couple and broadcast them, but it's a neurosurgical procedure where right here between the elbow bone and the medial malleolus, you have a nerve that runs right there in that little groove. It's called the ulnar nerve, and it runs down and goes to these two fingers right here, your pinky and ring finger, and innervates the skin here. So people get that nerve pinched right here in their elbow. We go in and surgically unpinch it. It takes 10 minutes to do. I'm going to do that for one of my patients, and that's going to be our last surgery for the day. It's very quick surgery. So hopefully you can stick around. Have a nice